Hey Fix listeners, I want to take a minute to give you all an update on our DPO, Smile Now Dental Group. In case you haven't heard, we've been opening up locations all across the country for doctors just like yourselves. We started several offices this year to show proof of concept, and it's been off to the races ever since. So if you're looking for an equitable partnership opportunity where you can have a profitable business that supports you doing full arch, I'd love to hear from you. We're looking to add several locations in the next year and want to offer the training and support necessary to make one of those yours. If you'd like to learn more, you can go ahead and hit me up on Instagram at Dr. Tyler J. Tolbert, or shoot me an email at tyler@smilenowdentalgroup.com and say hey. Now, without further ado, let's get back to the show. My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Poppy,
And you're listening to the Fix Podcast.
your source for all things implant dentistry.
Yeah. So that actually, I think that transitions us pretty well into my next topic. So we talk about, the dangers that come along with, placing pterygoid implants. That's what you mentioned, Dr. Damon. We can get disoriented, right? And even when we're doing freehand surgery, and we've done it a million times, it's very possible to get your eyes tired. Maybe you're a little bit off angle. Maybe you thought you had everything locked in, but you got deviated, or you just got a whole lot deeper than you expected to. And so one thing that a lot of doctors are proponents of is guided surgery, even guided pterygoids as well. And so one thing I did want to talk about is the role of guided surgery specific to full arch. So it's one of the most hotly debated and polarizing topics in all of full arch dentistry is, should we be doing this guided or should we be doing this freehanded? So advocates of guided surgery are going to be touting the predictability that comes from it, the precision, being able to get implants in the correct location, and being able to reduce the risk of complications that can arise from the sort of human error that you just mentioned, Dr. Damon. So conversely, though, advocates for freehand surgery would argue that working without guides allows for a lot more flexibility and the ability to react to complications, anatomical variations. We have all seen where you've got a CBCT ahead of time, you thought you knew what you were getting into, and then you open it up and something was totally different, right? So Dr. Stanley, you were a huge advocate for guided surgery, and in your video, I place guided implants in even the toughest cases. You stated that guided surgery can be done anywhere in the mouth on any patient, and the implants placed guided are more predictable, have decreased rates of infection, and will undergo less mechanical stresses. Conversely, as for Dr. Damon, you have stated in the past that freehand surgery completed with proper training allows for the most flexibility in trophic cases and the ability to pivot to the use of zygomatics or other remote anchorage techniques when things don't go as planned. So Dr. Damon, I'll have you expound on this one first from the freehand side of things.
Sure. So, all of my cases are guided, and they're brain and anatomy guided, and that allows a open mindset. I can react to whatever type of situation occurs, and we've all seen it. We've all had it. We have evaluated a CBCT beforehand, and we've let's just say it's a simple infection. I have watched these apical infections grow to much larger than what the CBCT shows. And I mean, I have taken infections out that have traveled, three teeth, anterior or posterior to that. We can all say that we reduce that we extract teeth atrophically. But on occasion, you can definitely fracture a buccal plate, and you have to be able to pivot. So I advocate for freehand in all cases. Some of my most stressful cases were ones that I did guided, and maybe I didn't set up the cases how Dr. Stanley may. However, this was using, the Nobel guide. This is back in 2014, 15, and, really long drills, because I always want to maximize my AP spread. And so how can I maximize my AP spread if I can't even get the drill back there for your posterior angle? In addition, whenever you do a guided case, or at least my experience and what I hear from other individuals, is that you leave your brain in your office and your brain did not come to the surgery room, because you have given it up the second you've walked in the door. You've said the guide is going to be my guide, and I'm going to do everything that this guide tells me to do. So we don't have an open mind when going in to do guided cases. And I would challenge, you guys have seen my cases. I think if you look at my x-rays will look better free-handed than they would look guided. Even with the Yomi, I look at other Yomi doctors, I look at their x-rays, and I'm just like, okay, there's lack of symmetry. These implants aren't at the same depth, and I have not been impressed with looking at Yomi x-rays. I know that's dynamic guided, but so my position is open mind, freehand, and I think it's in my hands is safer and more predictable. And I'll tell you this, the guys that come and guys and gals that come take my courses, they seem like they have a weight taken off their shoulders when I tell them that they can do the cases freehand. They are like, oh my gosh, Dr. Damon, thank you. And I think it saves them money. I don't know what current guide prices are. But I mean, I remember the days where guides were several $1,000s a piece, and I'm a huge proponent of just save money and give it to your kids. So to me, things that we can do that lower cost is a win for everybody. So those are my thoughts.
All right, Dr. Stanley.
So, I often hear the statement, I want to be able to adjust during surgery. I want to be able to pivot, or whatever the term you want to use. And I'm always shocked at when people say that. And because when I approach a surgery, I approach it a little bit different. Let me explain. In engineering, we do something called an optimization problem. So if we're going to design something, let's say we're going to design something, okay? We don't want to make it bigger than it needs to be, but we don't want to make it too small. We want to make it just right, okay? So if you make a screw too big, it costs more and it carries too much weight. So if you're trying to launch something into space, you don't want big screws, right? But if your screw's not big enough, then your spaceship falls apart. So there's somewhere in the middle where the screw is the exact best size for that solution. In engineering, we do it all the time. We typically do it through mathematics. Okay, we say through math, we say, what's the optimal solution? When it comes to dental implants, I optimize my implant location prior to the surgery. So we do a virtual surgery. So we're going to do the surgery on the computer before we ever do the real surgery, right? And what do I mean by that? Well, we're going to virtually place implants. Those implants are going to be optimally placed. They're going to be the optimal length. So as we were talking earlier, we want to stay, 18 millimeters is the ideal range for the pterygoids, not 25. So there's a reason for that, right? So when you're designing your case, you're saying, what is the optimal length? What is the optimal diameter of my implant? Where would be the absolute perfect location for the multi-unit to stick out of the gums so that it would be in the perfect location for my screw access hole for my zirconia prostheses? You see what I'm talking about? So we're going to start with the teeth. Then we're going to back into where the exact perfect implants are, the number of implants, the size of the implants, the locations, and all of that. And now we have the perfect plan. There is no deviation from that plan that is going to do anything for you but make the system worse. So when you go in, so this is a concept, if you've been practicing for a while, people will say, well, the concept of the rescue implant, you guys recall the term, the rescue implant? So this comes from the old days when the metric for success was, did the implant stick in the bone? So we used to say, when we did a surgery and we walk out of the surgery, we go, the implant's in the bone, that was success, right? That's how we used to measure success, really, literally. And so the way that worked is I tried to put an implant in and I got a spinner. So you turn to your assistant and you go, get the next bigger implant. And so you put a bigger implant in the hole and you get primary stability and you're done. Okay, great. But the problem with that concept is that if you could have placed the bigger implant, you would have started with that in the first place. Okay. The reason you didn't start with it in the first place is because theoretically the implant you put in that spot in the first place was the optimal implant. So if you could only get a 4.2 millimeter implant in a premolar, and you say, well, okay, I don't have stability, so get me a bigger implant. So you say, well, give me a 5.2 now, right? What happens? You blow out the buccal bone. Now you get stability, you get it to integrate, and then you get into Hissens and the facial, and then you don't get integration long term. You get temporary integration, and then you get a soft tissue dehiscence, and then you're calling up your periodontist friend and saying, I need a connective tissue graft and a bone graft or whatever to try to solve this problem, which the problem was the implant was the wrong size. In this case, if it was the wrong size, just by going to a bigger implant. Well, it's the same thing with these surgeries. At what point in my surgery would I want to pivot? It's shocking to me to think that while I've got someone under sedation, that I would change my plan. You see, my plan was optimized in the comfort of my office, drinking a cup of coffee with no one bothering me, where I was focusing on that patient and optimizing the solution for them, such that when I go to the surgery, there is no pivot. So the concept of I'm going to leave my brain in the other room, yeah, that makes a lot of sense, because when you go in, at the time that you go in, it's time to execute. It's time to execute the said plan. It's not time to change the plan. It's time to execute the same plan. And I don't know when people say, well, there could be things could change. The landscape's not going to change. The volume of bone is not going to change. All of your planning is not going to change. Even if you have more infection than you thought, your plan doesn't change. Like, you just had more infection than you thought. But if you're using good standard practices for primary stability, you're going to be able to predict your primary stability, and you're going to have a success. You're going to have a win. So that's kind of how I look at it. And I look at the surgical guide as a tool. It's so some people get really upset about this. They as you started with the introduction here, you said this is a hot topic, right? So you got people are like, hey, no, freehand is the way to go, and that kind of thing. I'm not religious about this. All I'm saying is it's a tool, and if you have a tool that can help you accomplish your goal, which is laid out, then why not use it? I like to make the analogy: you're building a house. And while you're building a house, your hammer breaks. Okay, it's 11 a.m. and your hammer breaks. And you have a choice. You can pick up a stone and you can keep driving nails with a stone, or you could go to Home Depot and get a new hammer. Okay, and I think most of us would say, okay, hey, Joe, hold on a second, I got to go get a new hammer. We pause for a minute, we go get a new hammer, right? So that's the concept of, hey, if it breaks, I got to go back to freehand. If my guide doesn't break, if it doesn't work, I got to go back to freehand. Well, that's never happened in my career. Now, I've had plastic break, and it predicted, most of the the guides that are broken were early on in the practice, like early on in the years, back when the guides used to cost a lot, and those plastics were weak. So, you can print the guide in your office now in minutes with a Sprint Ray printer, and your print cost is about $2. And then you put a master cylinder in there, and the master cylinder is about $12 to $15, depending on the company you're using. So you're looking at a total hard cost for you as a surgeon of around $15, and then you got to pay, of course, your overhead for your labor and such. But the old days of guides costing $500-$600 and such, those days are gone. Now, for full mouth cases, the guides are still a little more expensive because typically you're using a company to help you plan those cases. And so then you get on a go-to meeting, you review the case with them, and you verify that the positions meet your design, your surgical goals and your prosthetic goals. So those can cost a little bit more. But the benefits is that I did a case on Monday, upper arch in 34 minutes from beginning to end. So from laying the flap, placing the implants, closing the flap, and placing the prostheses in 34 minutes, that's pretty powerful. And the reason why we were able to do that isn't because of me. It's not that I have any sort of God gift or anything like that. It's just that if you follow the method, it becomes very, very predictable. And I have just the opposite, Doc. I have people calling me after they've been placing implants freehand for 10 years. And they literally are like, holy shit, I can't believe that it was this easy. I'm sorry, I cursed on your podcast.
No, please. We do it all the time.
So they're like, I can't believe, I can't believe it was this easy. I remember back, I'm old enough to have done freehand back in the day. And I remember placing implants and then going, okay, take the radiograph. And I'd walk out in the hall and I'd lean up against the wall and I'd be like, counting the seconds, wondering if I hit the adjacent tooth. And I
Mm.
walk around, I always made sure that the radiograph was up on the back screen, not in front of the patient. I needed to see that radiograph first. And I would look and I would like, oh, whew. Mrs. Smith, it looks great, you know, and then all the stress would go away. And the minute you go to guided and you know you can get a guide accuracy of about 200 microns, 200 microns is your positional accuracy with a guide, all that stress goes away. Now, you do have to plan it right. It doesn't, the brain part still you still got to have the brain part. It's just the brain part has to go into the planning part, not during the execution. You still have to you still have to be smart during the execution. But that's my take on the guides.
Yeah, I think we're able to optimize our implant position clinically, and I can tell you, my implants, I am typically able to get greater AP spread during surgery than I thought that I was able to when I was reviewing my X-ray and plan before, and so. I don't, we're very open. I mean, there's a number of times, even when you follow key principles, right? Like perforating the floor of the nose with your posterior implant, lifting the nasal mucosa, being able to reach in there and have total control and total feel and have a bear hug and a grip on this entire patient anatomy, to where, on some cases you've chosen the correct implant. You just didn't have the correct patient, and that patient just systemically has a lot of challenges, especially with their bone. Postmenopausal females, whether they have teeth or not. I mean, I look back at over the past year, I have had I can think of three patients right now off the top of my head that had teeth. We extracted, we did, just our standard all on X procedure, and, even placing the smallest drill and compressing that bone, going to the floor of the nose, going to cortices, using all of the principles that I teach. I had no torque on 3 implants. I've had 3 patients that have wound up with a quad day of surgery that had teeth due to their bone. And so
did they have stability though? They had 0 torque. Did they have stability?
Hey guys, I just want to take a beat to talk about one of our sponsors, SIN 360, specifically their full arch digital workflow. Here at the Fix Podcast, we've been using SIN for about 2 years, and one of our favorite integrations from this workflow is the Micron Mapper. Photogrammetry is an absolutely pivotal technology that has changed the way full arch is being done. It's allowing us to capture implant scans in under 5 seconds with micron level accuracy that's beating any type of scannable verification jig or analog verification jig, what have you, and it's able to do it in under 5 seconds. And guys, SIN 360 is absolutely giving this thing away right now for $699 a month for 39 months with 0% financing. Think about that, $699 per month. That's about the cost of an analog conversion or fabricating an analog verification jig, or maybe even just a scannable verification jig. So I highly, highly, highly recommend you try this out. It's one of the most pivotal investments that you can make in a full arch digitally capable practice. To learn more, visit sin360.us/thefixpodcast and get yourself a Micron Mapper today.
Well, if they don't have any torque, I mean, I don't load. I don't know. I mean, if I don't get, again, I practice predictability. And so if we can't get 35 Newton centimeters of torque with stability, I'm not going to load it. And so we are going to deviate. We're going to deviate every time, and we're going to go to zygos, and because we are going to predictably load. And so deviation in my perspective is hugely beneficial for that patient, and hugely beneficial for the case success. And now they move along, they get 1 surgery, 1 procedure. Yeah, it was bigger than what they intended, but because we can shift on the fly, we're able to treat that patient better. and we're able to optimize that case's outcome by pivoting.
Interesting. So let me
Dr. Stanley,
go ahead.
I have a quick question off what you said. Do you load? Are you saying that you load your cases if they are? It doesn't matter the torque necessarily, as long as the implant is stable. Is that what that you were referring to there?
Yeah, that's what I was going to go into that right now. So
Okay.
so
I'm curious. Yeah.
the idea of a cutoff at 30, 32, or 35 Newton centimeters for your insertion torque, um, it, it, it's an interesting concept. Okay, so and then you put it together for full arch. A lot of times people talk about the cumulative torque value, right? So you hear, if I don't have 120 across the arch, I'm not loading. So let me just start off by saying this. I have loaded every single upper and lower case I've ever done in my entire career. I've never had a case where, and they're all guided, and I've never had a case where I didn't load it. And that includes all the bone quality. And we're working on the same patients, guys, right? We're working on the same 55-year-old patient with poor quality, right? They're taking a minimum of 3 meds. Some of them are, pushing eight meds, right? Those are the people we're working on. They're not healthy. The bone quality, the bone volumes, it's not there, right? So you say, well, how is that possible? Well, it comes down to a couple of different things. Number one, when you freehand and you are hitting 2 different types of bone, you're hitting spongy bone and you're hitting compact bone. When you're freehanding, you can't hold trajectory. No one can. I don't care if you're Arnold Schwarzenegger. You can't hold trajectory, okay? So you can try, but you can't. If you're placing a small implant and you go in and as you're doing your osteotomy, it's wiggling. In one time you're going this way and the next time you're going a little bit different. The osteotomy that you made is not the right size. And so you get an implant that has no stability. It's just floating. It's a spinner or it's floating, okay? So that's the first thing that you can have. When you do guided and you're in crappy bone, you're in the same crappy bone, the guide is going to constrain your drill and it's going to hold you on target for every single drill. So the small drill, the medium drill, the bigger drill. Then the implant goes through the guide. So the implant is being constrained too. So if any of those things hit hard compact bone up against spongy bone, they don't get knocked out of position. Okay, they stay on target. So that's the first thing. You're going to get an increase in primary stability by using a guide because you're going to actually stay on target through the entire osteotomy and drill and implant placement. The second thing is that we've been kind of misled with the concept of torque. Okay, so most dentists have taught that torque equals stability, and torque does not equal stability. And I'm going to prove it to you in the next 30 seconds, and you're going to be shocked. Okay, here we go. Ready? You're going into a patient on the lower anterior. They're 60 years old. They've been wearing a denture since they're 19. You know that lower anterior bone is going to be rock hard. There's no spongy bone. It's all D1 bone, really, really hard bone. It's all compact. You drill your osteotomy, right? You drill your entire osteotomy protocol. And because it's D1, you're going to do something called tapping the bone. You guys remember the taps? They used to have taps in the kits in the old days. So you're going to get your tap, and what your tap is going to do is it's going to cut a groove in that D1 bone. You're going to cut the helical spirals where the threads are going to go. So you go in and you tap it, and then you take the tap out, you grab your implant, and you put your implant in the hole. What would you think your implant torque would be in that case? 0.
Low.
Yeah, maybe 3 Newton centimeters. What do you think your stability is? Your entire implant, 10.5 millimeters long, surrounded by 2 millimeters of bone, compact bone, all the way around it.
Yeah.
You had 0.
So it's not going to move, but yeah.
Exactly. And you've got 100% stability. You couldn't wiggle that thing out if you tried. If you got on it with an ash forceps and you tried to pull it out, you couldn't pull it out. The only way you're going to get that out is put a reverse torque on it and back it out along the path of the threads. Mm-hmm. So now you're starting to think, wait a minute now. Maybe we've been misled with this concept of torque because people are so fixated on torque that they're changing their protocol and they're saying, well, I'm not going to load this case, or I'm going to pivot in real time and add extra implants in other locations because my torque was low. Now, I'm going to tell you right now, I have loaded every single case, and I record the torque for the treatment notes because people still think it's the standard of care to record the torque, right? So we record it, but I record 16 Newton centimeters, 12 Newton centimeters occasionally on implants around the horn. I don't care. As long as I can screw the multi-unit on there without it moving, and I can attach it to the rigid long-term provisional, that implant will integrate and you will have success. So it's a complete paradigm shift. And that's why I keep saying cumulative torque value is a man-made construct. It was made by us. Where do you think 30 Newton centimeters came from? Why 30? Isn't it coincidental that the Brandemart implant, which was made out of a soft grade 1 titanium, had a limit on it at 30 Newton centimeters because the abutment screw stripped? So imagine you're an early implantologist, the guys that are actually now the old guys teaching at the universities, and they kept saying, be careful about torque, be careful about torque, be careful about torque. And what they were really worried about is stripping the abutment in the implant. They weren't talking about the implant to bone, but over time, it's very easy to see how people would mistake that and think we're talking about torque to bone. So the fact that we're using 30 for that is arbitrary.
Yeah, but a lot of your thoughts there, I think, apply to mandible, but doesn't apply to the maxilla. So, for example, Malo's initial study, 245 patients, mandible, they had 98% success, and obviously these were the older implant styles. When they went to the maxilla, they had 30% failures. They did not have a stability or a torque requirement, and so once they raised that to load it, then their success rates went to 97%. So yeah, I mean the maxilla is just different bone.
I'm curious, Dr. Stanley, about loading everything, right? So even if you get less than, say, 20 Newton centimeters of torque, is that to say that you just maybe like hand tighten a multi-unit onto the implant?
All of my multi-units are hand tightened. There's no wrench at the time of placement.
Okay. And then are you using, so you use the tap analogy, which that's super interesting. The torque versus stability argument is very interesting to me. So are you actually tapping the bone when you use a guide, or are you just using a traditional drill that's just going to make that hole? Like, is it tapped prior to the implant going in to give you stability in those D3, D4 situations?
No, I haven't used the tap in a long time. The tap analogy is just to try to get you to think differently about the concept of torque.
Okay, it reduces
the concept of torque being torque is stability, which is it's not. So you just have to keep that in your mind. Now, clearly, if you have higher torque, what you're doing is you're putting there's more compression of the bone from the implant going in. So the idea of undersizing an osteotomy, meaning that you made the hole smaller, means that when you put the thread in, it's going to compress the bone more. The bone is going to, through Newton's laws, is going to push back onto the threads. You're going to record that as torque. But really all it is the compression of the surrounding bone. But the funny thing is that you could go into a socket and engage compact bone at the apical aspect of the socket and engage just 2 threads and have 100 Newton centimeters of torque. And the rest of the, say it's a 12 millimeter long implant, you could have 10 millimeters of that implant floating in the socket with nothing around it. And the bottom 2 threads could be engaged in compact bone, and I've done this, and you will measure 100 Newton centimeters of torque. Okay, now, do you think that has good stability? And the answer is no, because any sort of load, even putting the abutment screw on there, if you just wiggle it just a little bit, it's going to avulse it right out of that hole because there's only 2 threads engaging.
Yeah,
but if I go into D4 bone,
movement.
Pardon?
Yeah, any lateral movement in that scenario would.
But if but imagine this: I go into D4 bone subantral, and I've got 10 millimeters of D4 bone, and I put a 10 millimeter implant in there, and I get 15 centimeters of torque. Do you think an off-axis load with my screwdriver, with my 050 driver, is going to avulse that implant? And the answer is no. But even though the bone is like styrofoam, even though the bone is very soft, the fact that you have all 10 threads engaging the bone is going to be more stable at 15 Newton centimeters with 10 threads engaging than 2 threads giving you 100 Newton centimeters of torque. Do you see? So this is a paradigm shift that is really important for people to understand, because it changes the way you think about how you do implants. So even if I'm going into a healed site and it's D4 bone and I have low torque, which is what you would expect, I don't care. I don't care because I have stability. It's not going to go anywhere. And remember what we said, the prostheses that we tie to the top of this acts like bracing. It holds everything else together. So the common term is cross-arch stabilization, right? That's what people like to call it, right? Cross-arch stabilization.
Mm-hmm.
The prosthesis is not a prosthesis in engineering. It's a prosthesis in dentistry. In engineering, it's bracing. So if you put a post in the ground with cement, you would put some triangular 2x4s around it called bracing to hold it while it sets up, okay? In the mouth, when we place the implants, we're going to brace the implants with the prostheses. We're going to hold all of those implants in place with the teeth. Dentistry, we call it the prostheses. Engineering, we call it bracing. But they're doing two different things, aren't they? So by tying it together, you get that cross-arch stabilization, and you're going to get great outcomes. You're going to have just wonderful outcomes. And I don't ever calculate cumulative torque value.
So I do agree. I don't calculate cumulative torque value, and it doesn't apply in my hands because we're getting 360 plus cumulative torque value for all of our arches. But while your implant subantrally at 15 newtons may be quote unquote stable, and while I do agree that we do have a bone splint with all of the abutments and everything glued together, just from a predictability sake, I do think that would work on occasion, but it's just not predictable. And so in my offices, I can't, we're doing 25, at least for me, I'm doing 25 to 30 arches a month plus my associate. I don't have time to basically have failures. And so that's where I opt for a more predictable approach.
I'm gonna have to reiterate something. I have never had a full arch case not loaded, and I've only had 2 cases where I've had catastrophic failures, or they were both on smokers in my career. So it's either I'm lying, or I'm gifted by God, or the third option is the method works. So I would hope you guys would take the first 2 as kind of funny, but the last one is the truth, and that is if you follow the method, you get great equipment. I tell people, listen, if you turn the Toll House cookie bag over and you follow the instructions in the back, you're going to get good cookies, right? And so if you're not following the instructions, you don't get good cookies. And so with respect to implants, if you follow the method, you'll get great outcomes. I don't have time for failure. I despise failures. I'm a winner. And when I have a failure, I lament it for days. I mean, it drives me crazy, and it drives my wife even more crazy. So
if I were to paint a portrait of the 2 opinions here that are opposing, that claim to be reaching the exact same result, right? So on one hand, we have less implants, high cumulative torque value, even though, Dr. Damon, I know that you're not necessarily saying that's what it's all about, but less implants, high torque value is creating stability with rigid fixation. Alternatively, Dr. Stanley, fairly irrespective of the torque, you have more implants that are rigidly fixated and you're getting the same success rate. Is that idea that because you have more implants that are being fixated to each other rigidly by the material itself, be it the nanoceramic or the zirconia, that's why the torque doesn't matter, and that's why you're able to sort of get away with doing the short implants being placed actually because of that fixation, regardless of the individual torque on the implants? Is that, I just want to make sure that I'm characterizing your argument correctly.
So first of all, I don't think that we have much of a difference in the number of implants, because I believe that the vast preponderance of your cases are going to have 6 implants, and so are mine. Somewhere
the number of implants
are about the same
per square area, right?
Okay, like so the AP spread. Right. So there's a bigger AP spread. Well, the AP spread is the advantage of the AP spread is to have a terminal abutment and to reduce your cantilevers, which is it's a good mechanical principle, right? It's one that we drive to. If you do use a cantilever, just keep it short, right? And then if you do have a cantilever, your beam has to be thick enough. It has to be made out of a strong material, and the implants that you're using have to be strong. So there's a lot of implants out there that are grade 4 implants. They're 36% weaker than titanium alloy. So if you see, you're following the recipe now, right? So I just gave you the Toll House recipe here for success. If you have a cantilever, it should be short. If you have a cantilever, your prosthesis should be made out of a strong material, zirconia. It should be tall, 13 or more millimeters in height, so at FP3. And then your implant can't be a weak implant. You have to use a strong implant. And then the last thing is your implants have to be in the right location. So they can't be just haphazardly placed. They have to be in the right location to support the loads. Okay. If you put all that together, you have a recipe for success, irrespective of cumulative torque value, irrespective of individual torque value. And I believe the reason that they integrate is because they're not moving. So it's not about your initial torque that gives you stability, that gives you a win. It's about lack of movement, right? If we have movement during the healing, if the implant moves, it won't integrate. You'll get fibrous ingrowth, right? We all agree on that. I don't think there's anybody that would argue, go ahead and wiggle it and see what happens. It just doesn't heal. But when you have implants and they're in bone and they have stability and you tie them together, they don't move. There's no movement. We don't let them chew on these teeth right away. Okay, so just to be clear, my protocol is they're on a liquid diet for 2 months. Okay, and that's rather extreme. People will say 2 months. That seems like a long time. Can't you go shorter? Guys, if you've been practicing for a while, you know that when you ask someone not to chew on teeth for 2 months, you'd be lucky if you get a month, right? You know how that that rule.
I know that for sure.
So we're going for 2 months of liquid diet, but that's the goal. And if I can get to 2 months, and I've had three or four patients that actually did it, and we know how we know. When they come back at 2 months, they've lost 15 pounds. We don't have to ask them. They just go, God, doc, I look great. I lost 15 pounds. Thanks a lot for the benefit, But that's how you know that. But most people are probably eating on it. But the fact is you're driving for that initial stability being no movement. No movement is the key. That's key. So it's not torque. It's not compression of the bone. That would be necessary if you had the idea that you were going to let them go out and chew on those teeth right away. You would have problems, right? Because now you're going to need to have higher stability based on engaging more compact bone rather than just bone in general. So then you're going to go to bicortical stabilization and those kinds of things.
So for your guided cases, just I'm curious, are you doing stackable guides typically?
So yeah,
or are you doing?
Yeah, so I worked really closely with NDX back in the day with the initial guys that created NDX and created those patents. So it was really instrumental in giving them feedback, which helped to improve the stackable solutions over the years. Then some of the guys from NDX spun off and started their own businesses. And what they did is they made an approach that is not stackable. So S3, Simple Smile Solutions, is one of the candidates, one of the companies I work with closely now. It's not stackable. It's fully guided, but it's not stackable. And one of the advantages of that with the new system is that they invented the original system. So then they said, okay, what can we do better? They can take a guided case and they can actually provide it to you as a clinician with like 3 or 4 parts total. Like you could do the whole case with three printed parts. It's amazing how they have really streamlined it. So stackable solutions work great. There's a lot of them out there. There's a lot of copycats now. I don't know how they're getting around the patents because there are patents out there, but they're getting around it. I think that probably because there's so many people doing it, it's hard to just go after them all. But stackable solutions work really well. But a lot of the copycats are starting off with stackable solutions that are about 7 years behind the technology. In other words, the original stackable solutions are being copied versus the evolution of the stackable solutions that have occurred over the last 10 years. And the evolutions are subtle, right? They're very little subtle details in terms of how you actually implement a stackable solution to improve the workflow so you can do it in an hour, right? And the new guys, you got to be careful. What I'm just saying to the people that are listening, if you're going to use a stackable solution, I would really encourage you to go and look at somebody who's been doing it for a while. And not to say that the new guys can't do it, but I would encourage you to look at the way the guys that have been doing it for a while are doing it, because they have had the feedback and they've improved their systems. So that's my suggestion on that. Did you have a question about the stackables?
Yeah, and it's just more of like a predictability thing too. Just a couple points that I think are important to address, and I'm curious how you manage it in your clinic. One of those things is if you're doing, I guess the better point is, I see people that have issues with guides, right? When we have a situation where maybe they plan the case as a stackable case, and then they go in and they, let's say the patient has like 10 to 12 teeth, and those teeth are severely decayed, but really good root structure. And they go in and they're taking the teeth out, and all of a sudden they have a fracture buccal plate on one of the roots. And that's a location that your implant is planned and guided. And they have this stackable case in their office that they paid X amount of dollars for. And that's a key position for one of those implants. And, it probably wasn't, could have been the provider's fault, right? But maybe it was just a really difficult tooth to come out, and that buccal plate fractured off, and it was in one of those key positions of their implant. And doesn't matter what the torque value is or the stability is of that implant, but it's in a very critical position that now they can't use anymore. It's no longer usable. What is your solution in that situation? How do you manage that for a new guide? Do you go replan the case, print another guide in your office? What does it look like in that situation? Do you then go freehand in that situation? And if you do go freehand in that situation, you're if the guide is stackable, right? You have the teeth prefabricated. I'm just curious how you'd manage that in that particular situation. And I feel like that's a pretty common thing that might happen.
Yeah, that is. So first of all, I'll say in my course, I offer a 1-hour lecture on how to take out teeth without that happening. Okay. So it used to drive me crazy. In school, the oral surgeons would come in and said the best way to prevent, the best solution to these complications is prevention, right? They used to say that all the time. Case selection and prevention is so important. So first, learning how to take out teeth atraumatically. So you'll never have that happen. If you take my class or you watch my video online on my YouTube channel, you will never break a buccal bone ever again in the aesthetic zone. Ever. It just won't happen. Okay. So it's just that simple. People are shocked. I got compliments this week, and I was at Affordable's annual meeting, and I had people coming up that recognized me, and they were thanking me for the extraction video on how to take out teeth atraumatically. So if you haven't watched that, check it out. I think you'll get a kick out of it, or come to the class and you'll get even more details. But in the aesthetic zone, you will never fracture another buccal plate ever. In the posterior, if you're taking out a molar and using some 88s, and you've got an old person, it's brittle, it's possible that you could fracture some of that. Okay, so you do have to be careful there. But let's just say that you did have this happen. Okay, for the sake of the argument, because let's say you just did. All right. Well, we're doing an FP3. So typically with FP3, we're going to do longevity leveling. So longevity leveling is after you take out the teeth, you're going to take off the bone is going to be jagged, right? And we want a nice level bone. And the reason we want a nice level bone is that when we build the prostheses, it's nice and smooth, it's not concave, and the patient can keep it clean, and you got longevity, right? Because they can keep it clean real easy. So when we level that bone, what do we do with the bone? Well, we don't throw it away. We have autogenous bone, which is the gold standard for grafting, right? So what am I going to do with it? I'm going to put it in my bone mill, I'm going to grind it up, and I'm going to have it ready. So at the time I'm done with the implant placement, I have a 4-wall defect. So I have the apical, the lingual, the mesial, and the distal are all intact, but the buccal's missing. I got stability on the implant, so I'm going to graft around it. I'm going to graft with what? Autogenous bone. You want to talk about having an amazing outcome? Graft with autogenous bone. You can't buy bottle bone anywhere that's as good as the human bone. It has all the growth factors, osteoinductive, osteoconductive, it's all in there. You heard Craig Mish talks about it all the time. It's the gold standard for grafting. So I'm going to graft, and I'm going to put a collagen membrane over it, cross-link, and I'm going to put some PRF over that, and I'm going to get primary closure. And I'm going to close it up, and I'm going to tie it with the rest of the teeth, or with the rest of the implant to the prosthesis, and I'm going to proceed. It's a simple solution. Now, how do I know I'm going to get, even without the buccal bone, with the buccal bone blowout, did I need that for stability? And the answer is no. We rarely engage the buccal bone with an implant. Rarely.
Yeah, I wasn't saying you need it for stability. Right, I was mainly concerned with.
Yeah, just so that anyone was getting confused, we don't need that buccal bone. We're not trying to engage that buccal bone for stability. And that's how we would manage it.
On the subject of,
and that makes sense. I do the same thing. Every single case that I do, when I'm removing my bone, I typically use a ronger and then use a bone mill, grind it up, and then use that for my graft and all my sockets. And I think it's a really great outcome. And I was just curious how you manage that. The second question I have is in an office, right? Let's say like an office like Clark's office, where and maybe your office too, I'm not sure how many arches you're doing in your office, but some of these clinics that are doing 20 plus arches a month, Do you think it's predictable for those offices to be paying for guides for all their cases, and then also managing the production, ensuring that whoever you're hiring to make those guides is doing it well and going through all these cases with them? Is that like a huge time constraint for you? Have you found it to be pretty efficient at this point? Where are you at?
Yeah, so all the data acquisition is done by my team members. So I have a patient who agrees that they're interested in doing full arch or full mouth. All the data acquisition is done by my team members. Then we sit down once the data is sent to the planning company. The planning company plans it. Then we do a go-to meeting. That go-to meeting takes me about 5 minutes now. And most of that is just chatting with my friends on the other side. But we're going to step through each implant and we're going to verify position and it meets all of our guidelines for placement, right? And so that we're done, okay? And then the guide shows up in the mail a couple of weeks later, whenever, depending on the time frame. And we schedule the patient for surgery. We go through the normal medical clearance. And we get them in, we do surgery, and we do all of our cases are sedated, and we do it. So I'm in and out for, on average, I'm doing an arch in an hour, on average. Sometimes a little bit more, sometimes a little bit less, but on average it's about 1 hour per arch. So imagine you're doing a high volume clinic. So you start at 8, at 10 o'clock you're done with the first case. From 10 to 12 you take a donut break. At 12 you start your second case. At 2 you're done. You just did, if it's $70,000, $70,000 for full mouth, you just did $120,000, $140,000 of production in 4 hours. If I'm a DSO or if I'm a high volume practice, you got my attention. That's a business model that I can spend a few $100s on making a piece of plastic to have this kind of production. Now, here's where people don't understand. I saw a patient today who drove down from Virginia. So that's about a 3-hour drive from where I live. They drove down to see me because they had an all-on 6-placed screw retain that they never were comfortable with, and the doctor took the prostheses out, went to a locator solution. They weren't comfortable with that, took out a couple of the implants, and he came to me with 3 implants and a denture. He said, "Can you help me?" Okay. So this is what we see in our practice all the time with freehand. It's not that, just to be clear, it's not that you can't do freehand and be successful. You can. But if you really, really want to be predictable on each and every case, and putting it into the hands of, say, somebody who's not quite as gifted, right? Right. So some people are gifted in dentistry. They have the hands of Michelangelo, right? And others aren't. So implants are a great place to live if you're doing guided, if you don't have hands. If you have a hard time doing crown preps, then implants are where you should be because you don't have to have that kind of dexterity. I routinely place my implants and do my osteotomies with my left hand so that my hand doesn't get in the way of the video. And so you go, well, isn't that dangerous? No. Yeah, I'm in a guide. The guide's constrained in the position of the drill and the implant, so there's no risk to the patient. But I do that so you guys can see in the clinical videos how to do it. So if I'm running a business and you tell me not only can you do it faster, but I'm going to have less downstream complications, less bad Google reviews. I never got my teeth. This guy's saying, I never got my teeth to work. I paid for full arch, and now I'm down to a locator denture, and the guy was even talking about taking out their 3 remaining implants and doing a denture. He's going the wrong way. Usually people start with dentures and work their way into locators and then to full mouth to a screw retain. So the poor guy was going the wrong way. So I can build a business model that's just the opposite of what most people will tell you. That if you really want to be profitable in full arch, then you want to do fully guided. And you can bring these services in-house. If you're big enough and you're doing this, you just bring that design service in-house. And now you're really driving your costs down. And you can get a printer. You can even have a design service done in Egypt and have the guide printed in your office the next morning. So
I was going to ask you that. So
pardon?
Are any of your guides, I was going to ask you about that next. Are any of your guides printed? Are you typically, it sounds like you would get yours shipped in, but have you tried, it sounds like you have printers in your office. Have you tried printing them in office? Has that worked well for you?
Yeah. Most of our full mouth, no, but we have done that before. But because full mouth isn't normally, I need full mouth tomorrow, right? There's never really when they come to you, it's not like, oh, I've got to do full mouth tomorrow, right? There can be time pressure, like I'd like to be done by May, in a couple of months for my family reunion. That can happen. But typically you don't have that time pressure that you have with a onesie twosie implant, right? So the onesie twosie implant, somebody has an acute affection and you want to do it immediate or something like that, then you want to print it in the office right away. That makes a lot of sense. But for full arch, typically you can wait. But if you really are pressed for time, and sometimes that happens, you just talk to the design service company and you have them send you the print job straight to your printer and print in your office. And that's really another subject you guys can talk about in the future on your podcast is the globalization of the globalization of dentistry. And you can have, listen, Egypt is sleeping right now, right? And in a couple of hours, when we're off this podcast, they're going to be waking up. So they could be planning your case while you're sleeping. And you wake up, the case is planned. So talk about efficiencies, like, and it doesn't have to be Egypt. I'm just saying somewhere else on the planet, you can have a design service. And so what we're going to see, in my opinion, is that you're going to start to see digital laboratories, a consolidation of the digital technology into some big laboratories that do the planning for everybody. And they're going to be super efficient. They're going to know exactly where the implants need to go. Each doctor could have their own set of preferences. This is exactly where I'd like all of my implants to go. If they're a pterygoid, this is where it needs to go for optimal solution. And they do it digitally, and then you just get on the computer and you verify it. You give it thumbs up or thumbs down, and you're done.
Dr. Stanley, one point that I did want to kind of clarify.
I appreciate it. Thank you, by the way. I appreciate the insights. Yeah, go ahead, Todd.
Yeah, no problem. A point that I did want to clarify in terms of the stability of the implants, even in softer bone, right? And I'm trying not to conflate this with torque, though it's hard.
No, it is hard, isn't it?
It is. So is the idea that because you're placing an implant along a constrained path, that the implant is inherently more stable, irrespective of torque, because it's constrained? You talk about, and you have a video on this too, when you're trying to place it freehand, you're going through heterogeneous bone, right? There's areas of D2, D3, D4. Your drill is glancing around a little bit, and you're actually widening the osteotomy a little bit in different places. Is your idea that because it's guided and it's constrained, the implant is being tapped in and you have better bone to implant contact, that is giving you some stability as well? Is that part of the argument too?
That's correct.
Okay.
That's absolutely correct. So what happens is that if you're freehanding it, you're feeling the bone. So a freehand dentist will say, I like to feel the bone. I like to feel that tactile feel. And that makes sense because you can feel it, right? You can feel I'm hitting hard bone here. Oh, I know what that is. You're visualizing the anatomy in your head as you're drilling, and you go, oh, I know what I'm touching up. That's what I was looking for. That's the feel. So they're feeling it. The problem is that as that drill goes in, if it goes in this way and it comes out a little bit like this, it now made a hole it's wider than the pen, right? It's wider than your drill. So now you go in, your osteotomy hole is bigger than you wanted it to be. It's not as tight as you want. So remember, the idea behind undersizing an osteotomy is to make it smaller so that you have more compression of the bone, so you have better stability, okay? Well, if you're going in there freehand and every time you go in a slightly different angle, the final hole you get is not going to be designed. In engineering, it's called the pitch diameter, okay? The engineers have designed the final drill to match your implant specifically. And if you waller that hole out, that's what we say in the South here. We say waller it out. If you waller out that hole, the hole is going to be bigger. So you've done the opposite of osteodensification, right? You've made the implant more loose in the hole. And that's more inclined to give you something that has zero stability, basically a spinner or zero stability.
Right. Well, so the antithesis of that is, of course, and Damon, I'll let you finish there. Sorry. The antithesis of that idea is, the idea that we can anchor extra long implants in only just a few millimeters of bone, right? And that's really the whole concept of a remote anchorage implant, is we're able to still get stability just off of just a few millimeters of density. But sorry, Dr. Damon, I didn't mean to interject.
Well, I was going to say that, Waller, I don't even know how you say that. Waller.
It's not spelled. It's only said.
Yeah, there's no spelling for it.
That is obviously not the goal of freehand, right? So saying that happens in freehand is like, well, that could happen into a more inexperienced provider, but not. That doesn't happen. That's not a applicable statement to all freehands.
So I will argue the contrary to that in the following way. compact bone is 10 times stiffer than spongy bone. So the modulus of elasticity of compact bone is 10 times stiffer than spongy bone. That's why we call it spongy bone, right? I don't like to use cortical bone or trabecular bone because it muddies the water. We're going to call it spongy bone because it's soft like sponge. Okay, so now it's almost like this little foam on my microphone here. It's spongy. And compact bone is 10 times harder. So the problem is that whenever you hit compact bone anywhere in the mouth, that drill is going to kick off that compact bone and slide into that soft spongy bone every single time, with or without experience. Now, with experience, you can learn to try to compensate for that, right? You learn with time. I'm feeling it, so I have to push this way or that way to try to get my implant on the right location. But it is a mechanical constraint, not a clinician. It's not a hand skills. You see, it's a physics issue. You are going to if I asked you to place an implant and I wanted you to drill right on the edge of the bone. So the bone is compact and on the other side is air. Well, pretty much anybody can't do that, right? But I can do that with a guide. Do you see? One side's air. So as you try to drill down, this side over here is bone and this side over here is air. As I try to drill down, right halfway on bone and halfway on air, it's going to kick out into the air every time, right? Unless I have a guide. And if I have a guide, it's actually going to cut a semilunar cut on the side of the hard bone. So that's the difference. So the difference is that instead of using air, so I use air as an analogy so people can kind of understand. But if one side is spongy and it's 10 times weaker than the other side, it does the same thing. It gets knocked off that hard bone. Now you say, well, where's the hard bone? Well, the obvious location for hard bone is where we all know it to be, and that's on your cortical plates, right? Your buccal plate, your lingual plate, we all know that. But vast preponderance of these people are not coming at us with healthy teeth, right? So a lot of times you have focal sclerosing, don't you? You have idiopathic sclerosis apical to your extraction socket. So I call those little landmines. So you're going in, you're thinking everything's great. You get towards the bottom and all of a sudden you hit some of these hard bones, the hard, dense, bony islands. And at the very bottom there, your implant gets out of position a little bit. And for onesie twosies, the free-handed dentists go, oh, that's not exactly where I wanted it, but I guess it's good enough. And then they leave it. And then what happens? It integrates because the first rule of implantology is if the implant's placed in the wrong position, it integrates. Right.
Integrates, yeah.
We all know that. So then what happens is they put a Snoopy on there, and then the Snoopy's on there for about 2.5 years, and then the screw loosens. And when the screw loosens, the abutment loosens, and the abutment breaks the implant. And they go, what happened? Well, it's 2.5 years, and the most dentists say what? Mrs. Smith, what did you eat last night? Because clearly it was working for 2 years. You broke this. And then they put the blame on the patient. And this was a problem that started the day that the implant was placed. And we see it all the time. And we have the benefit of the time because these failures, they fail through a mechanical mechanism called cyclic fatigue, right? Fatigue failure. Fatigue failure is if I have a coat hanger and I bend that coat hanger back and forth really fast, it gets hot and then the coat hanger breaks. So if I have an implant and I bend it back and forth enough times, it will break, okay? And so in our case, that typically takes about 2.5 to 3 years before it starts to break. Depending on the implant you use, if you use a weaker implant, it's going to break readily. So the time difference is our saving grace, because if these things broke within the first week, we would all be changing our methods. They're not breaking in the first week, so we have this time between the placement and the failure, and we have what we call plausible deniability. We go, Mrs. Smith, what did you have for dinner like that? Like what she had for dinner the night before caused the failure, right? That's not what caused the failure. It all goes back to the implant was placed in the wrong position and it was a weak implant.
Well, I mean, I think that guides have a place for single implants, just not in full arch. And so, which brings up a really good point. You know, as you were talking, I haven't done a single implant in probably 3 years. All I've been doing is fixed arches, which is really nice. You know, we have ways to navigate, you know, kind of around those. You know, for me, I really lock my wrist, and you know there is no wrist bending. But you know, I don't necessarily think that complications are due to lack of guide versus freehand. I just think that complications are due to a lack of ability to execute. And so That's where I think
I wouldn't disagree with you at all. I would say 100% you're right. It's all about the execution. I have an analogy. I say everybody goes to the Super Bowl or the World Cup with the plan to win. Both teams plan to go to win, right? And we all know, if we watch sports at all, we all know that typically the team that executes their game plan wins the game, right? It's usually the team that doesn't turn the ball over, that executes their game plan appropriately, that ends up winning, and they don't have the mistakes. I look at the guide as simply a tool to help me execute my game plan. That's how I look at it.
Mm-hmm.
Fair enough. Fair enough. Would you say, Dr. Stanley, you did kind of talk about, the role of DSOs and the potential, upsides of using a guided workflow. It seemed that you were inferring, though you didn't say explicitly, that a less experienced clinician, it can at least take teeth out atraumatically, would have more success using this guided workflow because it's not as technique sensitive. Is that something that you would agree with?
100%. The planning still has to be done properly. Because,
of course,
because remember, if you plan wrong, the guide will give you the wrong. The guide doesn't fix wrong planning, so you do have to be educated on the planning. So let's say the planning's done properly. We'll make that an assumption. The planning was done properly. Then I routinely have people do over the shoulder for their first implant cases, full arch cases, over the shoulder, and it's world-class outcomes, and it's the first case I ever did, and they have no experience whatsoever. Because it's just a tool. I have another analogy. Here's an analogy. If you do any woodworking, and you have to make repetitive cuts in the garage, you make a jig, right? If you do any clothing, you do any fabric work like sewing or something, you make a pattern, and then from the pattern you make the clothes, right? So the guide in dentistry is just like those two analogies. The guide just simply helps you get the implant on the right location. That's why I don't get real fanatical about it. It's just a tool. And if you can accomplish it without the tool, great. I just can't do it repetitively. I could do it occasionally. I just can't do it on every case. So then you ask the question, which patient deserves your less than best performance? Is it going to be your mom? Maybe your sister, your daughter. Who in your practice are you going to do dentistry on and say, I just wasn't on my game that day? So I would prefer to say my game is always A+, and it's always A+ because I use these guides, and the guides get me in the position that we planned to go. That's all.
I understand. Yeah.
Wonderful. Well, hey, I got a question. There's been a lot of talk. Stanley, I don't know how big into the full arch game your practice is, but what are you seeing on the East Coast? What are you seeing kind of in your market? And I'll just kind of tell you what I am seeing. What has been very interesting for me is every year I've been able to charge more for my arches, and and every year I'm doing more and more arches. Even being in Dallas, and as you're well aware, Dallas led the nation in fixed arches from probably about 2012 to 2018, 2019, and then it went elsewhere into Chicago and DC and Vegas. But so even in competition, I've been able to ramp up. I hear and I see other full arch heavy practices that are really struggling. And I don't know, do you have any thoughts on that? Are you seeing something similar? What are your thoughts in the market?
So my practice, I practice with my wife. We have been a fee-for-service practice since the early 90s. And so we still are fee-for-service. So our fees are set based on market value. And I do a lot of work with the DSOs, and I do a lot of work with recoveries of people that have had full mouth attempted. So I see them come to me. So we have a somewhat of a pulse on the industry. What I see that there are people that are trying to acquire volume by reducing price. And in doing so, they don't have the margins. And since they don't have the margins, they have to figure out a way to make it work. And the way that they do that is they they cut out tools, right? Like a guide, like they're going to cut the guide out, and they're not going to do 6 implants. They're going to do 4 implants, right? They're going to cut. They're going to use a cheaper implant. And I don't mean an inexpensive implant. I mean a cheap implant, one that's made poorly, because that's where they're going to save their money. You put all those things together and they can charge less, but they have a lot of complications and failures in the industry. And so I see in my area, I see a lot of problems coming to me from these big boxes, the big box companies that do lots of full arches and stuff. I get a lot of them coming to me after, guys, I got this doc, I got this done. Can you help me? And it's after the fact. And you guys know how hard it is, because you really want to help these people. And you go, oh my gosh, the implants, they integrated because they're in the wrong spot, or they're not deep enough, and you're trying to help them, and they basically have an FP1 with a high smile line and the transition showing, and you're going, man, guys, I mean, how did this even happen from the beginning, out the gate? It's frustrating for those of us that really care about the patients, and we're really trying to make a difference. And you want to help them when they come, and the only way to help them is you have to start the whole process over again. Many times. It's really frustrating.